Hello, everyone. I think we can start now. Most of the of you are here, so allow me to share my screen. And I will hand over the admission to Dr. Salem and also Chris. Can you see my screen, Dr. Salem?
Yes, I can see. Yes, you can go ahead. Yes.
Okay, no problem. I know now it's not full screen. Good morning, good afternoon, good evening, colleagues, partners, and distinguished guests. On behalf of Sun Yemen Secretariat and the multi-sectoral technical team, I'm pleased to welcome you to today's webinar on micronutrient deficiencies in Yemen, addressing hidden hunger among children and women. This dialogue comes at a critical point. As many of you know, micronutrient malnutrition is the silent unseen Yemen, continues to affect most vulnerable in Yemen, particularly children and women, despite years of programming from all the partners, from the humanitarian and also development actors. Yemen remains among the highest rates of micronutrient malnutrition in the world, and we still face gaps in coverage, data, coordination, and action. Today's session brings together key national actors from the health sector, Ministry of Health, and also from the other nutrition sensitive sectors. Here we have also their key partners from the UN agencies, UNICEF and WHO, alongside the global partners, Micronutrient Forum, Nutrition for Development N4D, the Healthy Diet Coalition, and also Emergency Nutrition Network. We're here not only to examine the evidence, but also to push for joint responses that are adaptive, inclusive, and grounded in Yemen's reality. Let me take the opportunity to thank all of you and all the contributors, especially the speakers and also the facilitators. Your experience and engagement will be invaluable, and we will explore the practical avenues to strengthen nutrition programming in Yemen. I will now hand it over I will just, I hope that you can see my screen. I will put it in, yes. So the expected outcomes is, as I said, to strengthen the visibility of micronutrient challenges in Yemen, to share understanding of data
Karima,
gaps. Yes.
We feel
Karima, the slide is not moving.
Yeah,
It's not
I
moving?
think it is moving now.
Was it moving or no?
No, not for me here.
Okay, no problem. I will keep it small, no problem. So I was saying that the expected outcomes is also to share the understanding of data gaps and programming needs, practical recommendations for multi-sectoral convergence and policy advocacy, identifying the entry point for future collaboration. This is the nutrition situation in Yemen. I'm not going to present more details. It is almost half of children under 5 in Yemen are stunted, and we have more than 70% of prevalence of anemia among the women. So this is, how it looks, looking at the geographical reality of Yemen. So I will hand it over to Dr. Salem. Over to you, Dr. Salem.
No, thank you very much, Karima. And colleagues and partners, welcome to this webinar. And this is a very interesting webinar, as it is for the first time we have such a webinar and a dialogue about the micronutrient deficiencies in Yemen, which is one of the hidden hunger in the country. So welcome to this interesting dialogue and discussion. And we have a numbers of panelists from national and international expertise. We have here from UNICEF, Najib Abdelbaki, who will go to us about the nutrient deficiencies in the country. Najib is a senior nutrition specialist in Yemen, working for UNICEF. We have from WHO, Dr. Ishraq Al-Falahi. She's the nutrition acting lead in Yemen, and we are pleased to have her in our discussion and our webinar. We have Dr. Minar from the Ministry of Health. She's the director of micronutrient deficiency program within the nutrition department at the Ministry of Health in Yemen. Welcome also to Martin Mwangi. He's a program lead from the micronutrient fund, and he's leading the Healthy Mothers, Healthy Babies consortium. We have also Lina Mahi from WHO. She's the cross-cutting lead partnership for safe, healthy, and sustainable diets, Department of Nutrition and Food Safety from WHO. And we are also lucky to have Heather, senior nutritionist from the Emergency Nutrition Network. So welcome to all. And with this, we will start with our first panelist, Najib Abdelbaki. Over to you to go through the discussion and the presentation. We have 15 minutes, so colleagues, you can also pass if you have any questions through the chatting, and also Karima will help also in collecting the questions, and we will revert back to you with responses. So thank you to all, and Najib, over to you.
Okay. Good morning, good afternoon, good evening, good day, everyone. Okay, I'm going to have the first presentation. Thanks, Karima, for arranging this meeting, gathering all of us in this special, session, an important session actually for Yemen. So I'll keep my camera off, just to maintain the bandwidth. And now I'm going to share my presentation. Well, please let me know if you can see it.
Yes, please. If you could make it in the full zoom, yes. Thank you.
Yes, thank you very much. So I'm going to talk about, it's like kind of history about micronutrient deficiencies in Yemen, and some of intervention has been taken during all of this time. Like I'll go back with you, something like more 30 years ago. So I hope I can do it, in the best way. So as a background, let's tell you that is, of course, there is no recent survey done to assess the micronutrient deficiency in Yemen. Although there is attempts in the past to do it, and the last attempt was in 2014. But of course, now we are in emergency situation, so I know that most of stakeholders are not giving this priority to this area, which is really very important area to have to be addressed. So we will have some of old surveys that mostly they are subnationals or small studies done by some researchers. The most important focus is given to let's say that those anemia, vitamin A deficiency, xerophthalmia, vitamin D deficiency rickets, iron deficiency disorder. Some of these assessments also include biomarkers, some including like clinical science, some are subclinical. So some are also, focus on like food consumption. So not all of them have are really covered what you call it, either the subclinical or clinical science. This is really the cascade of the micronutrient malnutrition. So if you start from of course, the poor dietary intake. So that is one. So if there is poor dietary intake, in addition to, and let's say that is extra utilization of micronutrients and or increased requirement of losing the micronutrients, this can do what you call it depletion of the body stores of micronutrients. So like I will just give very, very, very quick examples on the what you call it extra utilization of micronutrients. Like for example, like in rapid growth period, like in physical stress, if in some cases if you are exposure to some toxins or pollutants, like chronic diseases that affect the nutrients absorptions, like measles, for example, it can affect the absorption because it affects the epithelial cells of the intestine, so the absorption of nutrients in general can be affected, or maybe sometimes some parasites can affect and do like bleeding or losing of the nutrient loose. There is also some of in some cases, like in women, the increased needs of iron because they are losing a lot of iron every month. And and also there is in Yemen some of iron, let's say iron absorption inhibitors, which is a cat consumption, because cat has some of compounds that, like I think tannins, that can affect and phytate also, that can affect the absorption of iron, and there was really good studies has been done in Yemen for cat on this and it is effect on the pregnancy outcome, like the babies, which really cause low birth weight in babies. So all of this can affect and do really, if it is affect the stores of the mother and the child, so that is then we can start see the ongoing now what are the changes happening, like biochemical change. For example, let me give you, for example, if there is depletion in vitamin S2, the retinol store. So what is going on to happen in the biochemical change? You can see that is the vision compounds rhodopsin cannot be created. So, and that is can lead to another functional environment that is like for example, you can maybe there is effect also on the immune system. They maybe you cannot see or you cannot you cannot have the performance or of your cells is not going to be in well situation. There will be, for example, in children that can happen. What you can see that is like the reduced growth because of this. Some of chemical reactions like those needed by the body to produce the energy. To make enzymes active. All of these things will happen, in the body, and then at the end will be reflected as a clinical symptoms. So that end stage is the clinical symptoms. That is something you can see. Like, for example, in vitamin A deficiency, you can see children with potato spots or whatever is the other symptoms. And before clinical symptoms, all of these things, we call them subclinical. Subclinical means the effect is there, but the clinic, you cannot see it. You cannot see them by your eyes, but maybe, by tests, like you do the lab tests and those things. So this is one of the old, as I said, this is one of the old studies or surveys done in Yemen for vitamin A deficiency. This is done in 1992, but then published in 1996. That was supported that time by UNICEF, and it was published in the European Journal of Clinical Nutrition. It was done also in Tehama, which is in the western of Yemen. So if you can see, at least there is 3 clinical symptoms that is exceed the WHO, that's what we call definition of the severity of the problem. Forget about night blindness. Also, it is existed there, but maybe the way they are asking the question, the mother about the blindness in the children maybe was not, reported well. But the others, the 3 others, are clinical signs, means the doctors who were involved in this study have seen these things. So, like beta spots, they have seen it there, and in the percentage, that is, if you can see, is like 10 times the WHO more than the WHO threshold of definition of the sign. And this is a subclinical of it. That is done. They have assess what you call it, serum retinol, which is a vitamin A stores in the body. So you can see that is also the stores was depleted because the levels of those have serum retinol either below 20 micrograms or below 10 micrograms also are exceeding the thresholds of the WHO, the definition of the problem. That's time in Tehama, it was the word, the word Ashawan, even that was reported before that survey, even in 1970 something, or maybe the nutrition surveys done in 1979, the word Ashawan was there. Ashawan means blindness, but in Tehama, in Tehama, their local language. So, which means blindness. What we have seen that is this blindness or this word Ashawan is start to be reduced. Actually, Adra started too early there to work with in Tehama to do the vitamin A supplementation before it becomes like part of the national immunization days, starting from 1997. Then the word started, not heard. Maybe if you can, in some area, I don't know, but it's not heard that much. Yes,
Dr. Najib, since you don't have a lot of time, I think you might need to move a bit faster. Eh?
Oh, okay.
Yeah.
Okay, I will do.
Yeah.
So this is the anemia among children. This is the anemia is coming from the DHS. That is the last survey we have in Yemen. It was in 2014, and also high levels of anemia among children and women. And let me say that is the same levels we have seen here in the children is those same levels we have seen in the survey of 1979. So even something nothing that is in children, there is nothing about women in that survey. This is the IODD or the iodine deficiency. This is also a subclinical, that is urine and iodine in urine, but also shown that is is increase the population who have the levels of or low levels of iodine in the urine increased. Already, sorry to say that, but it's increased to from 31 to 50%. So it means that is half of population have this low iodine levels in urine. Other micronutrient deficiencies also in many studies we have seen since 1939 reported in many other in many old literatures. That is, for example, rickets. And
Najib,
most of them are
Dr. Najib, we remain 2 minutes, please. If you can conclude in 2 minutes, thank you.
So it's the most of these studies really for the rickets were just clinical, not subclinical. But let's say that is in general, don't go to the symptoms and no symptoms. If we look to the intake of the food that we take, I think most of the population are not taking much the food that is enough to give them the quantities of micronutrients as advised or as recommended. That's why you have stunting with this level. Having stunting with this level means that is the people have not enough food and nutritious food to eat, which means that is also low in vitamin E. Chronic energy deficiency is high in among women. That is half, like quarter of women still with are malnourished. So the micronutrient, what you call it, the minimum dietary diversity is high among children. I mean, children are not even having the food that is the good. I mean, the diversity of foods that can if they take, then can say okay, they can take their micronutrients, and also the time that. So let's go to the approach for intervention. That is, we know, and some of them have been used. We have food fortification. That was the first thing that started in 1990, was by iodine deficiency, by salt iodization. Then come after that oil fortification and wheat fortification. Oil fortification with vitamin A and D, and then flour fortification with iron and folate. The supplementation is ongoing with these activities now. Many of you know that vitamin A supplementation is going. Iron and folic acid supplementation is given. Multi-micronutrients to children, that is powders. This is really another approach is for emergency. Usually it is an emergency that is also we having them in our program. Dietary diversification, that is not much working. But so dietary diversification is approach that is you promote that people is having the food that is diversified. So there is another, like for example, as supporting or promoting the house and school gardening. Some of promoting some food processing at home. Education. Biofortification is not there. Biofortification, that is, you breed, some of groups have some, different characteristics, like potatoes, for example, that is rich, or sweet potato that's rich with vitamin A, or rich with other vitamin. So this has not been tried also in Yemen. For the public health disease control measures, yes, we have deworming now is working in Yemen, but not all parasites, not all worm, not, for example, such bilharzia, not other. So this is also the thing. So if you come to this, I don't know what has happened for this slide, so it moves up down, but if you can see this slide is evidence-based interventions by a group. If you can see this slides yourself, you can see many of them are evidence-based, are micronutrients-based interventions, or that is like helminth control, like all malaria control. So you can see how effective that is a micronutrient or approach to improve micronutrition situation. Food fortification if I'm coming to give you the story about fortification, we have vitamin.
Dr. Najib, I think
Should I stop?
we can. Yeah, I think we'll reflect this few points later during the discussion. I think we'll provide you the opportunity to discuss more about the food fortification and salt iodization. But this is a very, very amazing presentation. Now we have this background about the micronutrient deficiencies, the story of xerophthalmia and vitamin A deficiency in Yemen, also the types of the most prevalent micronutrient deficiencies in the countries. There are a lot of questions like if there are any geographical variations about these deficiencies and the type of the deficiencies, and how about the proven interventions be scaled up in the upcoming period. So these some of the questions that will come later to Dr. Najib. And now I will let the floor to Dr. Ishraq Al-Falahi from WHO to come and have her part of the discussion in this webinar. Dr. Ishraq, over to you. She's the acting nutrition lead in WHO Yemen country office. Over to you, Dr. Ishraq.
Thank you, dear. I appreciate. So colleagues, good day. As my colleague said before, to all of you, it's an honor to be here, a part of this webinar, important webinar that we've been anticipating since long time. I will be presenting to you a few recent data on anemia that WHO is monitoring over the last few years. Dr. Salim, is my screen visible to all?
Yes,
okay.
loud and clear.
Yeah, thank you. So I will start just by a brief introduction about the WHO surveillance, how it works. But before we all know, I just want to remind all of us that we are off track on many of the SDGs targets, and including this target 2.2 on malnutrition, and to remind ourselves that yes, we've been doing a lot, but we still have room for to do better. So this is the general methodology. I think colleagues will touch upon that. And what I want to focus on is the last one of the endorsed methodology to monitor global anemia estimates, which is monitoring micronutrient status in population. So we consider nutrition surveillance system is among these to monitor this anemia levels. So how did this work? So in WHO, we have the nutrition surveillance system, which is a facility-based system. It is it covers it is in 317 facilities between primary healthcare facility and primary healthcare facilities. So it's a facility-based monitoring mechanism established to track nutrition status of children under 5 across the country. So the system is supported by the Ministry of Health and the WHO, covering 21 governorate out of the 22, and we will see the rates. So the assessments are conducted using standard anthropometric measurements, weight, height, length, MUA, clinical signs, and age-specific evaluation, which one of them is the anemia measurements. So we think of this nutrition surveillance system as a bridge for a humanitarian development nexus in absence of surveys, as mentioned by my colleagues. So this is the main indicators that is tracked by this surveillance. Sorry, my screen was freezed. I didn't notice, sorry. So as you can see here, over the years since 2018, more than 3 million children were screened. The proportion of wasting have been, more or less the same, around 25%. Proportion of stunting is 83.6% in average over the years. In some years, it was identified as more than that, but not less than this, than 40, which is consistent with the, SMART surveys results. So proportion of exclusive breastfeeding also up and down, because this is not a representative survey. It monitors trend based on the attendance rate on the facilities. Anemia here, as we can see, from 6 to 59 children, 59 months children, is around 20%. This is, it's always consistent like this, and more or less, within 5%, but it's there as long as we measure the children. And this is the edema. So if this is the children tool that we are measuring using this kit, and this is for PLWs, which we started recently to integrate as appearing here in this chart. So we are now converting to a more sustainable way of integrating nutrition indicators into existing maternal and child health service delivery platform. So in neonatal services, in antenatal care services, postnatal care, delivery room, and ongoing efforts to include other services. So these are the indicators that we have been monitoring. And as you can see in the antenatal care services, we are monitoring anemia by measurements. And in the delivery room also, we are reporting on anemia. This is the nutrition surveillance proportion of anemia between boys and girls. So the screened children 6 to 59 months, updated proportion is 23%. And between boys and girls, it's not relevant, but it's more in witnessed in girls, and this is consistent. This is the rate, the proportion over the years. And of course, because it's facility-based data, you can see that at one point it stabilized, because the rate is based on the attendance rate. And since there is no change in the attendance rate over the past few years, we see the same trend. Nutrition surveillance system, it did by boys and girls, and it shows that in all years, the girls, as I said, consistently the anemia is more apparent in girls than in boys. And this is the trend by governorate. We see that Al Hudaydah is the highest, preceded by Shabwa. And this has also, when we see such results, we go deeper into the sentinel sites to ask, and we have quarterly meetings with the GHO and GHO to discuss what is going on, because this is a monthly bulletin, and we can have a track of what happened. For example, at one point, our system was one of the first systems to track that there was severe acute watery diarrhea in the district, because there was a spike of wasting in that district. So these kind of it means nothing as a photo, but when it's explained in a trend way per district, per governorate, it has a lot of information to tell. And this is the monthly bulletin.
Thank you, Ishraq.
Yes,
thank you, Ishraq.
Thank you.
1 minute, if you could summarize.
Yes, this is the last one. And this is just because we just started more than 1 year to pilot measuring the women in the antenatal care and delivery room, only in 75 health facilities 2024. So this is the rate. As you can see, 44% of pregnant women found suffering from anemia by measurements, and the wasting identified in 17%. Thank you.
Thank you. Thank you very much. Excellent. And this is amazing presentation. Now we started to talk about anemia. And as indicated by Dr. Ishraq, it is one of the SDG target, and Yemen is behind that target. So it is interesting to have this topic here in this discussion. We have the commitment to achieve the target. We will come to Dr. Ishraq later on approaches to solutions and interventions that can address and improve anemia in the country. Yes, if we measure to the global targets, and the country is also still not reached the target, but Yemen is far from that target, so it is a priority area for the key policy leaders and for the Ministry of Health. So thank you very much. And with that, we would like to welcome Dr. Manar. She's from the Ministry of Health in Aden, and she's leading the micronutrient deficiencies within the nutrition department. Welcome, Dr. Manar, and over to you. Please take the roll.
Thank you, Dr. Salim. Hi, everyone. It's great to have this meeting, which mark a key step toward activating this and strengthening the micronutrient deficiency program. And thanks for the presentation. It's a great presentation, and the result that shows was very important. As part of Ministry of Public Health effort to reactivate the micronutrient deficiency program, it's data will we can collect more data than before through collecting data from different sources, especially anemia, vitamin A, D, and iodine deficiency, and specifically iodine deficiency, because I think there is no recent information that show how big the problem is in the country. And to fix this, we can maybe do surveys to indicate like iodine level in urine, the concentration of iodine in urine through survey. Also, the testing that done by CHVs in the households. And I think this will be like help understand the nutrition status in families and raising awareness about the importance of using iodine in salt. And according to regarding anemia, the ministry can collect from nutrition surveillance, and as well as we have another program that have the anemia indicators. I think it will be very helpful to make like a base information for this indicator, and we can plan actions to address the problem. I think all the steps that aim to build a complete and updated database to help create better health and suitable policies to support the national goal for nutrition and public health, and especially for this program. And thank you.
Thank you, Dr. Mar. Thank you very much. I think you highlighted a lot of opportunities for improvement, and also you highlighted the steps and the guidance and directions that the Ministry of Health can collaborate. Very interesting. And I think this will open a window for the partners to build on these steps and to work together with these steps. I think colleagues from different partners are hearing this from the Ministry of Health, and also we are happy to have and hear your questions. But also we want to hear the picture from the global perspective, and here we have some of our panelists from the international forum. So we have here Martin. Welcome, Martin, and he's the program lead for Healthy Mothers, Healthy Babies. And so it is interesting to have Martin with us. So thank you very much, Martin, and it is very interesting to have you here and to share the experience with our colleagues here in Yemen. So thank you very much, and over to you.
Thank you so much. Please confirm you can hear me and you can see my slides.
5 by 5. Thank you very much.
Oh, perfect. Colleagues, thank you very much for organizing this meeting, and I want to thank the organizers also for welcoming us to make a presentation as well. In the next 10 to 15 minutes, I'm going to walk you through what we were requested to speak about, which is basically the micronutrient situation at the global level. So present the global evidence and give you the implementation updates from other countries. I will try my level best to keep to time so that I give an opportunity also to the others to present. That said, my name is Martin Mwangi. I work for the Micronutrient Forum. I lead the Healthy Mothers, Healthy Babies Consortium, and I'm also an associate professor at Wageningen University in the Netherlands, which I'm sure some of the colleagues are familiar with. You probably know the Micronutrient Forum through the global conference that we organize every other 2 years. The last one was in the Netherlands, and the next one will be in Ghana next year. Perhaps when we meet this year, if you're coming to the International Congress of Nutrition in Paris, we might have an opportunity to tell you more. So the forum has other programs, but for today, that's not the focus. So I will just proceed on with my presentation. Happy to talk more about the forum. If you're interested, just send me a note. And so I will start my presentation by walking you through the global evidence that we have. And it's impossible to speak about the global evidence without spotlighting, again, the importance of good nutrition during pregnancy. What we see during pregnancy is that the life of a woman takes a huge hit. And now we are talking about the life of a healthy woman who goes into pregnancy. The first thing we know is that she will need a lot of energy, a lot of protein, a lot of even the macronutrients. The need for that increases, carbohydrates especially, to carry the growing pregnancy. And this changes trimester by trimester. We also see that, and this is a well-documented evidence, that she will need, in addition to her usual intake, 300 kilocalories per day. And in addition to that, there is over 50% in some cases increase in various micronutrients, vitamins, and minerals. And you might ask yourself, why 50%? And we are going to see that shortly. But before we go there, let's just say that the statistics we just got from our WHO colleague, but also the statistics from Yemen, they are really spot on. And we see the same situation reflected in many countries. 2 in 3 women of reproductive age are suffering from micronutrient deficiencies, especially in South Asia and Sub-Saharan Africa. So this conversation is coming at the right time. We need to discuss how we can support our women so that they can be able to carry their pregnancies to a successful end. What you see is that most countries have been providing to their pregnant women iron and folic acid, which is shown in red in the screen. And this is the standard quantities that you will find in almost all formulations: 400 micrograms of folic acid and 60 milligrams of iron as per WHO recommendations. However, if you go to WHO guidelines as far back as 1959, WHO already recognized that pregnant women do need support to get additional micronutrients. The challenge has always been how to deliver them in most regions of the world. Questions like cost, feasibility, the evidence was also not there to really support a strong guideline on this. And so what was recommended was iron and folic acid, and even today that still stands. And I'm going to come back to the guideline process. However, before we go there, let's just have a quick dive back into our biology books and ask ourselves, why would a pregnant woman for the 9 months require different micronutrients. And what we see is that different vitamins and minerals are needed in various stages of the growing fetus. There is a big assumption that just giving iron and folic acid all through, one size fits all will work. However, what we see from biology, very well documented, this is in all textbooks for medical doctors and nutritionists now, you will find that, for example, in the periconceptional stage, you will need vitamins B6, B12, folic acid. Folic acid and iron, just to be clear, does seem to be in most of the stages of the fetal development. However, there are others that are also important. For example, during implantation, you do need copper, iodine, selenium, zinc, vitamin D. If you don't have enough vitamin D, for example, if you look what is happening in the third trimester, there's a lot of neurological development of the fetus, but then the fetus is also growing. That's what it gains in terms of mass. So a lot of tissue deposition, body the composition changes, and for that vitamin B12 becomes important. But we also see other minerals and vitamins becoming very important. So if a woman is deficient in any of these during the stages of growth of the fetus, what are the implications of that? So WHO recognized that in various situations, we do need micronutrients. We have express guidance for use of MMS, multiple micronutrient supplementation during emergency situations. So for pregnant women who are in chronic situations, or maybe whether chronic because of maybe weather patterns, but can also be because of floods, acute situations, war. There, the World Food Program, for instance, distributes MMS to these women without any problems. That's the guidance is clear. The guidance for patients with TB is also very clear. And then in 2020, WHO updated its guidance to now have MMS in the context of rigorous research. So MMS is now recommended in the context of rigorous research. And in 2021, WHO also added MMS in the essential medicines list. And as you know, almost all countries usually try to match the essential medicines list with what WHO has. So this also opened the door for national essential medicines list to be updated. So a little bit about the update that happened in 2020. It was actually as a result of a lot of WHO studying a lot of pregnancies. In 2017, we had a Cochrane review that had studied around 113,000 pregnancies. And then in 2019, a Cochrane review that studied over 141,500 almost pregnancies is the one that provided the evidence that led to the update of the guidance. And what we saw in that update is that, or rather the evidence that led to that update is this, rather spectacular performance of MMS, where we are seeing that women who take MMS compared to only taking iron and folic acid, they are reporting 8% reduction in stillbirths. And in terms of stillbirths and in terms of small for gestational age births, 9%. And what you see if you look at the figure on your screen is that the statistics that were being reported on the huge numbers of anemic and underweight, pregnant women, they actually has most of the benefits. For example, if an anemic pregnant woman takes MMS, she could benefit from a 25% reduction in infant mortality, 16% reduction in preterm births. And the same case is observed for pregnant adolescents, which happens unfortunately, but this was also demonstrated, 19% reduction in low birth weight, 24% reduction in small for gestational age births. And many doctors and midwives will tell you these are really the risk pregnant women. And so we are always very worried about those ones. These are just the statistics. I'm not going to go into detail. This just shows you where the data come from to inform the figure that you just saw earlier, to complete with the effect estimates. And so we use these figures to generate the graph on the previous slide. So it's important to spotlight the 12% reduction in low birth weight, because world over we know when a baby is born, the first thing the midwife does is take the weight, because we do know that the weight of a newborn can predict the survival of that newborn. And so if you are able to impact this, also the gains for your public healthcare system is tremendous in terms of you don't have to spend now money taking care of these undernourished, underweight babies. Going on, we have just this year published another, and I have seen the lead author, Filomena Gomez, is in this meeting, where they showed that MMS goes on to impact the life of the newborn till 6 months postpartum. So they were able to report 14% reduction in stunting, 14% reduction in underweight. This is at 3 months, when they compared babies whose mothers took MMS versus mothers who took only IFA. And even having a low MWAC was reduced by 10%. Most program implementers will tell you that they really want to have an impact on stunting, underweight, small head circumference, low MWAC, etc. So these results speak for themselves. The only thing you might ask me is, from the slides I showed earlier, it seemed like MMS has 30 milligrams of iron, while IFA, iron and folic acid, has 60 milligrams. So in a country where you have a lot of anemia, is that a problem? And so a lot of work, again, has been done comparing 30 milligrams of MMS compared to 60 milligrams of IFA. And what we observe is that there are comparable effects of these two quantities of iron in both IFA and MMS. And we think it's because of the, most nutritionists have only focused on iron deficiency anemia. And we forget that there are other nutritional anemias, actually about 5 other nutritional anemias. MMS will impact anemia because of also impacting pathways that lead to anemia through vitamin A deficiency, B2, B6, B9, B12, C, D, and E, including the mineral copper. So that means you are approaching the problem from multiple directions, and that perhaps is the reason why 30 milligrams of iron is comparable with the 60 milligrams of iron. Moving on, in the interest of time, I will skip this one. This one basically just shows that the two are comparable. This is basically what I was just explaining in the previous slide, just showing that multiple comparisons were done: 60 milligrams versus 60, 30 versus 30, 60 versus 60, but now only of MMS. Not so. I think this case has now been nicely rested. Again, the doses of iron in MMS compared to IFA on neonatal mortality, we see that there was no statistically significant difference between MMS and IFA within any of the subgroups that were studied when it came to neonatal mortality. And at the end of this, and I will share these slides, I do have all these papers listed so you can interrogate them yourself. So what we see is that MMS is safe. The quantities of the micronutrients in terms of minerals and vitamins in MMS, even if a mother was having an adequate diet, let's say she has a balanced diet exactly as her dietitian would recommend, even if she goes on to add a tablet of MMS, this has been extensively studied. There are no significant differences in terms of side effects between MMS and IFA. So that was the first one that people wanted to know. However, this needs to be updated now because we are starting to get reports from Ethiopia, Cambodia, Burkina Faso, where women are reporting that MMS has far less side effects. We wait for that to be available online, and then we can update this slide. But in terms of being able to hit your upper level of intake, only in this case, iron would slightly surpass, but there are no known associated health risks associated with these levels. I think we all know that during pregnancy, the body upregulates absorption of iron because of the various needs that are there. So now no publication has reported any risk as far as MMS is concerned. So it's deemed safe. And when it comes to cost, if you log in now to the UNICEF supply division and look at the cost of MMS comparing to the cost of IFA, you'll find that iron and folic acid, your government, you probably be purchasing it at $1.50, whereas for a bottle of 180 tablets of MMS will be $2.50. I think if you go to the Treasury, the Ministry of Finance, they will tell you the value for money. I would rather be going for the bottle that gives me 15 compared to the bottle that gives me only 2. And economists have sat down and established that if a government invests in MMS, for every $1 that they invest, they are going to get $37 in return. In terms of lifetime gains, they have done everything, including what are the gains from the saved stillbirths, all those effects that I showed earlier. And on the right of the screen, what I show is basically the different packaging options. We can go into this later or in other sessions where if you want to know as a government, what should we be buying bottles or blister packs or whatnot. I can only summarize by saying environmentalists are in favor of the bottle because of the environmental impact. You know, you don't have to spend a lot to clean up your environment afterwards. So, ladies and gentlemen, in terms of the countries that have implemented MMS, we see a growing number of countries. In May 2024, we had 30 countries. In 2025 of February, we had 46 countries now taking up MMS. It seems that there is a momentum. We hope Yemen will also get interested and get on board and roll it out at national level. Most countries have been doing pilots, and then now we see Indonesia has made a landmark decision to scale up nationally. Sierra Leone as well is giving MMS to all its women. Ethiopia is on track as well. We also do know that some countries are at advanced stages of discussions with various funders to get national level support. So in conclusion, we have seen that MMS is safe, is effective, is affordable, is cost effective, and we now know that it's a UNICEF supply division through its various sources has made sure that the halal certified formulation is available for, you know, to ensure that there is cultural and religious acceptability in all regions of the world, including the labeling is also in Arabic and everything. So that women have really appreciated that. And when it comes to funding, mechanisms are existing. So a country can go either through the Child Nutrition Fund or the Global MMS Donor Alliance. And you can also coordinate with the UNICEF Supply Division to know which of supply mechanisms Yemen qualifies for. And then once you form up your national MMS Scale-Up Alliance, you are able to tap into all these opportunities. So I will stop there. Thank you very much for giving me an opportunity, and happy to answer any questions that you may have during the Q&A session. Over to you.
No, thank you, Martin. Thank you very much. Thank you, because we need this lecture in Yemen, and thank you, it came in the right time, because currently we are thinking about MMS for Yemen, and there is discussion and engagement between some of the agencies with the Ministry of Health. I am aware for UNICEF engagement with the Ministry of Health for piloting MMS in Yemen. And thank you for answering the key questions about the safety, about the cost. This is a very interesting, and it is really open a window for us for discussions, and we have some questions and comments, but this is one of the interesting and important presentation, Martin. So thank you very much. It is timely for us in Yemen. And thank you for this presentation, for all this information. Definitely we will come to you. I will go to the next presenter from WHO HQ, Dr. Lina Mahi. Over to you for your part of the discussion, and looking for the interesting presentation. Over to you, Dr. Lina.
Thank you so much. I would just like to first ensure that you can see the presentation.
Yes, thank you. 5 by 5. Thank you.
Okay, all right. Yeah. So thank you to the organizers for allowing the Coalition on Healthy Diets from Sustainable Food Systems for Children and All. It's a long title, so we say the Healthy Diet Coalition, to make a short presentation. I believe I have 3 minutes, so I will have to go quite quickly. But the PowerPoint slides are with Karima, so they can be shared later with you all. I mean, there has been a lot of discussion on micronutrients. That's the purpose of this webinar, and I welcome it. But micronutrients, how are they provided normally? That is through our diets. And hence that we want to make this presentation to you. Why? Because Yemen, from the onset of the establishment of the Healthy Diet Coalition, Yemen has been one of the front-runner countries, and even has been one of the steering committee members. So what are we trying to do with the Healthy Diet Coalition? We have different functions that you can see here. We would like to coordinate among stakeholders to align policies and actions across the food systems at country level, but also really at global level. We want to make sure that there is alignment and coordination. We advocate, we share knowledge, and we organize learning actions on healthy diets from sustainable food systems. And then we also have a specific focus on 3 themes, one being the dietary considerations in nationally determined contributions. That's the link between nutrition and climate change, the integration of sustainability in dietary guidelines, and also fostering healthy diets in fragile context. And here again, Yemen has been playing a leadership role. So who are we? We are a multi-stakeholder coalition. We have 22 real member states that are members, but we also have quite a large number of friends of the coalition, member states. You see the names of the countries here. The ones in bold are the current steering committee members, which are Brazil, the Netherlands, Pakistan, and Sierra Leone. But there is also a variety of UN organization and civil society. And you will see the speaker after me is ENN. ENN is also a member of our coalition. Hence the beauty of this coalition, because we asked ENN, oh, there is going to be this webinar in Yemen. You are our partner. Can you speak there? So we bring partners together to move forward on ensuring healthy diets from sustainable food systems. We've been active, and I can't list all the activities that we have been doing, but if you know about our functions of knowledge sharing, of advocacy, just in 2025, we were in the Nutrition for Growth summit in Paris, where we organized a side event. We were in May in the Rome Nutrition Week, again, where we organized side events and together also with the Agroecology Coalition. And my colleague Arganon, she is adding in the chat the links to the recordings and to the summaries of what happened there, so that you can still watch what has been happening. And also the One Planet Network Conference in Brasilia, also happening in May, where we contributed. And Karima specifically, as you can see in the plenary session, linking food system policies with nutrition, biodiversity, and climate. And also looking into the future, you probably all know that there will be the UN Food System stock-taking moment that takes place at the end of July in Addis Ababa. Again, our coalition is having a side event. There were like almost 200 submissions and only 28 were accepted, and ours, we're proud to say, was selected. The event takes place on the 28th of July, and it's again about breaking silos and fueling change, aligning nutrition and climate for food systems transformation. We will also be part of an inter-coalition session, because there's many coalitions that were established after the Food System Summit, and we will have a booth. So please come, if you are going to Addis Ababa, come and say hello at the booth. And we will also be attending the national conveners meeting that takes place on the 29th. We're also working on country case studies. I will not go into detail, but we have Ghana, Zambia, Sierra Leone, and Pakistan. Ghana and Zambia are finalized, but Sierra Leone and Pakistan are currently ongoing, looking and helping where are the opportunities to inject nutrition actions and healthy diet actions in the policies and in the programs that are taking place in the country. There will also be further webinars. And again, you see in the chat the link to the official side event for the food system stock taking moment. So to conclude, what's special about our coalition? Well, first of all, we are a coalition that was established because of the UN Food System Summit in 2021. We are member state led because our steering committee comprises the 4 lead member countries that I mentioned to you. We really have a holistic food systems approach. That means that we're not just looking at one item, which is complex and challenging. We look at the food systems as a whole, from production to processing, to marketing, to consumption, to ensure that across the food system, the policies are coherent and supporting each other and not working against each other. So we are focusing on ensuring healthy diets for all. You don't see that a lot in the coalitions of the Food System Summit, but we say that food systems transformation needs to lead to healthier diets. Many of our country focal points are from the Ministry of Health, whereas in other coalitions, it's mostly ministries of agriculture. And we say health needs to be at the center of food systems transformation. We have strong non-state actor principles of engagement because the role of the private sector can be problematic. Let me say that diplomatically. We have a collaborative spirit, working with many partners, with many coalitions, and we provide the global and country technical support. And if you want to contact us, here is the email. If there are participants of other countries or other non-state actors listening and interested to join, please contact us. And I will now probably give the floor to our member ENN. Thank you.
Thank you very much. And this is a great opportunity for all of us. And as you indicated, yeah, health need to be at the center for the food system. So this is an amazing presentation, Lina. So thank you very much for the presentation, for the links, for the contacts. I think it will open a window for our partners. Now I will go to Hida for the final presentation. Hida is from the Emergency Nutrition Network, and this is a good opportunity for our audience that the ENN is part of this webinar. So over to you, Hida, for your presentation. Over to you.
Thank you. Can you see my slides in full already?
Yes, thank you. 5 by 5.
Okay, great. Thanks for the previous speakers and for the invitation to participate. This is a really fascinating webinar to be a part of. I'm a senior nutritionist at the Emergency Nutrition Network. We work to reduce undernutrition globally, and we do this by enhancing the effectiveness of nutrition policy, research and practice. We share knowledge, we build evidence, we help to build collective action and collaborations such as this, and we provide resources and guidance to practitioners and decision makers. So I was invited to present some key findings and recommendations from our recent work on addressing micronutrient deficiencies, particularly among women and girls in emergency contexts. I do appreciate that some of these recommendations may not be applicable to the context of Yemen, but I hope they'll be useful. So I'm going to focus on 3 pieces of work completed by my colleagues at ENN. You can find all of these reports on our website, and the links were also provided in the concept note circulated before this meeting. So in 2024, we published our State of Play report on multiple micronutrient supplements with a focus on humanitarian emergencies. And this report was accompanied by 2 case studies from Somalia and Pakistan. We know that women and adolescent girls are disproportionately affected by conflict and disasters due to their increased nutritional needs and vulnerabilities. We also know that antenatal MMS reduces the risk of adverse pregnancy outcomes, and Martin has already presented these effects very clearly. However, there is limited information on the extent to which women and girls receive MMS in emergency situations. And where MMS programming does exist, details on implementation and barriers to scaling up are often lacking. So this report aims to fill some of these important gaps. I don't think I need to spend too much time talking about policy and guidance because Martin has already described those very thoroughly. So I'll skip on and save us a little bit of time. But we conducted a survey of 46 countries that were defined as experiencing a humanitarian emergency using UNICEF and GNC criteria. Respondents to this survey were asked whether MMS was provided for women and/or adolescent girls in humanitarian emergencies in their country. If the answer was yes, they were asked further questions about MMS distribution, suppliers, procurement, barriers to programming at scale, and whether MMS was included on the essential medicine list in their country. So you can see some of the results here in the table, and I'm pleased to say that they included 2 respondents from Yemen. Survey respondents were asked to state the top 3 barriers to programming MMS at scale in their country. Lack of funding was the most common barrier reported by 24 countries, followed by inadequate country policy, inadequate supply chains, and lack of awareness among healthcare workers and target populations around the benefits of MMS. And if you want to dig into the details of this survey, you can find the findings in our report. In addition to the survey, we conducted key informant interviews with stakeholders from governments, UN agencies, NGOs, and the private sector. We also had our 2 in-depth country case studies from Pakistan and Somalia. And from the findings of the survey, the case studies, and the interviews combined, we found that these 6 key themes emerged: leadership and governments, service delivery, health system financing, the health workforce, supplies and technology, and information systems. Barriers and opportunities were identified under each of these themes, and we've already seen some of those common barriers on the previous slide. And the opportunities in the report centre around tackling those barriers. The 2 case studies illustrate how Pakistan and Somalia have addressed some of these challenges in their own unique contexts and their plans for scaling up MMS programming. The report concludes that while humanitarian emergencies clearly present additional complex barriers to MMS programming, what is needed to address these barriers remains fundamentally the same in all settings, namely health system strengthening to make MMS programming as effective as possible within antenatal care services. Going back now to 2022, ENN published a broad report on the nutrition of women and adolescent girls in humanitarian contexts. We identified gaps in policy, research and programming, and this report was complemented by a case study from Madagascar. I hope most of you might have seen this report already because it was published 3 years ago, but if not, again, you can find the full report and the case study on our website. And for now, I'll focus on the recommendations that were most relevant to micronutrient deficiencies. So in relation to policies and guidelines, the recommendations included bringing together all relevant nutrition guidelines for women and adolescent girls, including preconception, pregnancy and postnatal guidelines, into one set of guidelines that can facilitate the humanitarian response. Secondly, we need clearer guidance on assessing nutritional status of women and girls, including field-friendly techniques for the diagnosis of micronutrient deficiencies. And thirdly, additional support from the UN and other partners so that MMS can be implemented in the context of a humanitarian crisis. In relation to evidence and programming, we highlighted the need for consensus on which standard indicators of nutritional status and intervention coverage should be prioritised in humanitarian and routine surveys to better prepare for and support the nutritional needs of all women and adolescent girls. Secondly, more research and pilot programmes on preconception nutrition interventions in humanitarian contexts. And these should explore which interventions are a priority and which platforms are effective for delivering them, especially in situations where schools may not be functioning or accessed by some girls. Thirdly, more evidence and disaggregated data to understand the nutritional challenges and intervention coverage for women and girls during the postnatal period is also needed. So following the publication of that report, we also facilitated a roundtable discussion and developed a policy brief in collaboration with the Healthy Mothers, Healthy Babies Consortium. And this brief highlighted 5 policy recommendations for preventing and treating micronutrient deficiencies among women and girls in humanitarian settings. 1, include MMS in the National Essential Medicines List. 2, improve the availability of micronutrient data and micronutrient status data in both development and humanitarian settings. 3, to develop, revise or update national guidelines and protocols. 4 was around strengthening coordination and funding. And 5 was to adopt a gender and nutrition lens to all health and social protection programmes and ensure that these programmes target the micronutrient needs of women and girls. More recently, in February of this year, we published a review focusing on school-aged children and adolescents in humanitarian contexts. This report highlights the vulnerability of adolescents, especially girls, to micronutrient deficiencies. The global prevalence of iron deficiency anemia actually peaks around the ages of 12 to 15 years when iron requirements are at their highest. And very few other micronutrient deficiencies are usually assessed in humanitarian contexts. At present, weekly iron and folic acid supplementation is the best evidenced intervention for non-pregnant adolescent girls, with a view to preventing anemia and neural tube defects in subsequent pregnancies. However, this report recommends that in emergency situations, providing daily MMS to all adolescent girls might be considered in place of weekly IFA supplementation. To see more about this and our other recommendations for school-aged children and adolescents, please check out the full report. And also look out for our forthcoming report on preconception nutrition, This is a review of evidence and guidelines, which will be published in the next few weeks. This report is not specific to emergencies, but it does focus on undernourished contexts. And we're taking a really broad definition of preconception as the time before pregnancy, including all non-pregnant women and adolescent girls, regardless of their marital status or plans for pregnancy. We identify gaps and recommendations across a range of interventions that are relevant to addressing micronutrient deficiencies. And finally, I'd like to highlight our flagship publication, Field Exchange, which is now in its 75th edition. So if any of you would like to write a short article to share your experiences of nutrition programming in Yemen, please do get in touch. And thank you for listening. I hope that was a useful overview.
Very, very useful. Thank you very much. Actually, I used to read in the NN the Field Exchange, and now interesting that we have this presentation in our webinar, and it is opening a window for all of our audience from various agencies to broaden their knowledge, and also the link to the NN. The recommendations are almost fit to our context, what I'm seeing from these recommendations, but thank you very much. With this, we still have 5 minutes, and we come to the end of our panelists. Now I'm open a window for the expert opinion, for the comments, questions. If you have, Josephine, please, over to you.
Thank you so much to all the presenters. And it's lovely to see faces that I've known over the years at a global level, present here today, making a number of the presentations. Mine is just to maybe recap and say, based on all that has been said and done from the context of Yemen, what are some of the 1, 2, 3 take-home recommendations that maybe with the support of the global colleagues we could be looking at? I would first of all maybe start with the overall situation. As you can see from the various presentations, indeed, there are quite a number of micronutrient deficiencies which were presented. But also I think what is key is the fact that the minimum dietary diversity and the food-based approaches are really not up to the scratch. And how do we ensure that that happens? And then the second bit I want to talk about is in terms of the response. In Yemen overall, I think the overall response, although Dr. Najib didn't go into that, also to showcase what are some of the coverages which would be shared, hopefully in his presentation. But what is clear is that the focus has heavily been on supplementation and the vitamin A, iron and folic acid, multiple micronutrients, and so on and so forth. But again, here for me, if you look at the low consumption of diversified food, then maybe the food-based approach, as well as the fortification component, which is really has been lagging behind, is an area that we could be focusing on. And then I know that there have been a number of presentations around the MMS compared to iron folic acid and so on. In Yemen, I think our challenge is one country, but 2 systems, if you like. I wouldn't say it like that, but from the context of if we are to update or a guideline, we have to bring the north, discuss it in the north, discuss it in the south, and then bring it all together, and then a guideline is issued. It's a very complicated process. So I think, yes, MMS, but we also need the support in terms of how do we ensure that both sides of the line ministries are on board to ensure that we adopt this systematically. Because let's say if it's only adopted in the south, it's a third of the country, while 2/3 is sitting in the north. And so that complexity would be something that we really appreciate your support in terms of the adaptation. Just to conclude that, I think overall then our really recommendation will be around updating the data, which is really old, as you can see. Yes, the surveillance data that has been presented by ISRAC is kind of maybe the updated one, but mostly all the micronutrients related data, including food consumption data, is outdated. So I support around that, and I was so happy to see that Zambia and Bangladesh has been some of the countries where we are piloting a lot of this, rolling out a lot of this, and this is because it's based on comprehensive food consumption and micronutrients survey data that have been involved in. And I really wish, regardless of the situation now, if something like that could be supported in Yemen, then it will set the basis for us to redefine what do we need to do differently to address this huge challenge that we see. And so I would then end by saying that the food systems approach is the way to go also, if we could also get that support. Thank you so much. Over to you.
The time is up.
Josephine. Yeah, we have, yes.
If we can take Wissam and Abigail, if they can just in a few seconds, like.
Okay.
Yes.
Okay. And then we have a closing. Then we have a closing remark from Chris. Thank you.
Okay. Thank you. Okay. Thank you. So over to you, Wissam and Abigail, just quickly to form your reflection.
Thank you, Dr. Salim. Just my point is, if we make the second round of this meeting, even we can just discuss very deep in this topic, because as you know, there is no much time to discuss more points. The second thing is what Josephine talking about, the guidelines and the specific indicators that we can working on, because as you know, as an example here in ICRC, we have multiple nutrition sensitive projects, but as you know, in the north or some places in the south, we couldn't conduct some indicators to reflect our nutrition projects. So if we can working on the guideline as soon as possible, it is professional for us. Thank you.
Thank you, Wissam. Thank you, Abigail.
Thank you so much. Yes, I agree. Another opportunity will be great to delve into this conversation. But just to summarize, I think one of the things that come quickly to my mind when we are talking about Yemen is we know that this is a food import dependent country, and therefore recommendations around how we can strengthen the policy and legislative framework around food imports will be great. And then secondly, on the MMS bit, I was also wondering whether there would be opportunities for support in country in terms of production, understanding the challenges that Yemen is facing currently on the importation process. Thank you, and perhaps we have another time to discuss in detail.
Thank you. Yes, thank you. Definitely, we will try to engage more and organize more discussion. I will let the floor to Chris to make the final remark of this webinar. Thank you. Over to you, Chris.
Thanks very much, Dr. Salim, and thanks very much to everybody for participating in this wonderful webinar. Thanks in particular to Karima and everybody in the Sun Yemen Secretariat for leading the organization of the webinar, and to everybody who's presented. This webinar has really highlighted the critical importance and priority of addressing micronutrient deficiencies in Yemen. Really addressing areas like a food systems approach to dietary diversification, the need for greater emphasis on food fortification, the need to focus in and improve the quality of data available that is the basis for programming. So the next question is, how do we move forward on this? How do we build on the analysis and the policy recommendations that we've been hearing about here and turn those into action? Well, it's going to happen in the context of the new Yemen Multisectoral Nutrition Action Plan under the leadership of the Sun Yemen Secretariat. And as many of you know, one of the key approaches to the operationalization of the new Yemen Multisectoral Nutrition Plan is the idea of accelerator programs. And I think the hope is that collectively we will develop an accelerator program around this issue. And I think as Karima will emphasize, we need to have another meeting of the multisectoral technical team in Yemen, where we discuss how we take these issues forward and develop an accelerator program on this priority that has already been identified as we've been developing the national plan. And I think we're hearing a sense of urgency for doing that around this issue. The Yemen multisectoral plan, we hope, will be launched at the end of October, beginning of November. And it would be great if we could have on the table at least an outline for what this accelerator program on micronutrient deficiencies would look like. I think that's all we have time for from me, but definitely moving forward, further discussion, but really towards a program that will help us scale up the implementation and coordinated efforts on this issue. Thanks very much.
Thank you, Chris. Thank you very much. I think we come to the conclusion of our webinar. Thank you to all of your colleagues. Karima, you want to say final word?
Yes, thank you so much for you, Dr. Salim, for this great facilitation of the webinar. And as Chris highlighted, also Josephine's comment and all our national partners, this was the aim of bringing the international partners, is just to show us the opportunities and also how we can work together. The accelerator program on the micronutrient deficiencies in Yemen needs all of you, especially at the national level, and also the support of the international level. So this is the final words from us, Sun Yemen Secretariat, representing the multi-sectoral technical team of Sun Yemen. And any final words to you, Dr. Salim, and this is the end of the webinar. Thank you.
Thank you, Karima. And with this, our webinar is concluded. Thank you very much, colleagues and audience. Thank you very much.
Thank
Have a
you.
nice day.
Thank you.
Yes,
Bye.
have a nice day. Bye-bye.
Bye.
Thank you.
Thank you so
Goodbye.
much. Thank you.
you.
Bye-bye. Thank you.
Thank you. Thank you.